Hi, I'm Dr. Mila Brujic, and welcome to the American Academy of Optometry Foundation clinical podcast series, where we're going to do a deep dive into some myopia progression management strategies here. Before we do that, I want to introduce our guests today. We're honored to have Dr. Andrew Pucker here with us. Dr. Pucker, please give a little bit of a background on yourself, just for those who aren't familiar with you.
Sure. Thanks for having me. I'm Andrew Pucker. I'm the Executive Director of Clinical and Medical Sciences at Lexitas Pharma Services. I am a kind of research coach there where I help companies come up with their FDA trials, and I also then help manage safety as things go along. And pertinent to today's interview, I actually ran the myopia control clinic when I was an assistant professor at the University of Alabama at Birmingham for about 5 years. So myopia is near and dear to my heart, and I'm happy to talk about that today with you all.
This is great because this actually makes this conversation so apropos to what you're doing and what you're currently involved in as well too, because what we're going to be talking about here is the efficacy of multifocal soft contact lenses in reducing myopia progression amongst Taiwanese school children. This was interestingly a randomized paired-eyed clinical trial. So this is a big topic right now. We're all looking at myopia and we're all looking at it progressing in preteens and teens, and even in adults for that matter. And we're asking ourselves, how can we slow this down? So when you take a look at this paper and you do a deep dive into this, why is this topic in this paper so important to us as optometry?
Sure. As we can learn from Brian Holden's famous paper on myopia prevalence, is about half the world is going to be myopic by the year 2050. And as optometrists, most of our patients are myopic. They come to us to get eyeglasses or contact lenses. So we're seeing maybe even a higher, rate of those people in our practice. We now, though, have the opportunity to provide options to slow their progression. Contact lenses, which is the topic of today's paper, is one of them. We'll talk more about that in a moment. There's atropine. There is orthokeratology. It's a contact lens, but it's kind of a specialty contact lens. And then in some countries, they even have spectacles.
Can you talk a little bit about the soft multifocal contact lens and really what the proposed mechanism of action is around slowing eye growth in myopic children?
Sure. With a contact lens, you can put it on, a regular spherical contact lens will correct your distance vision. But with myopia control specifically, we typically work with center distance multifocal contact lenses or presbyopic lenses, kind of. So lenses that allow you to see far away well, but also when you have that add in the periphery of these lenses, it actually brings the image shell within the eye. So it reduces peripheral hyperoptic focus. The image shell is within the eye. That's thought to be a stop signal. However, if the image shell is behind the eye, that's thought to be a growth signal. And it's kind of what the eye is chasing. The eye is trying to chase that image, but these contact lenses help avoid that.
So, Andrew, when I was in optometry school, I actually had an opportunity to work with one of the professors working on the chicken and the monkey models. And it was amazing just to see how they could induce these different refractive errors. But we want to spend our focal point here on this paper. Can you explain a little bit of the study design and what kind of results were seen at the various endpoints here in this study?
Sure. So this study took sort of an unorthodox approach. Typically in our myopia control studies, we have patients randomized to a treatment and patients randomized to a control. However, in this study, they randomized patients to one eye or the other. So they randomized, say, the right eye to the treatment and the left eye to the control. And they followed these patients for about a year. And what they found was that in the treated eye, they had a significant reduction in refractive error and axial length compared to the control eye. And actually, in some of these patients, they introduced some level of anisometropia, which we can talk about in a little bit. But overall, when we look at their data, it's, I think, a significant amount of reduction, but maybe not quite to the level of clinical significance.
Yeah, it was interesting, the selection of, randomizing one eye to single vision lens and the other eye to the multifocal lens, because there may even be a paired response here that we're starting to attempt at least to demask. But taking this a step back further, there's a lot of questions and discussion at the ground floor level with clinicians when we're fitting these individuals with various designs and looking at higher ad powers versus lower ad powers. The lower ad powers are obviously going to be much easier for children to adapt to and adjust to just because there's a less of a variance in the actual optical focusing than the higher ads. But is there differences in efficacy between lower ads versus higher ads? And what should we be doing or encouraging when we are fitting these kids in clinic?
I think the best study to refer to on this topic is Jeff Walleen's and team's Blink study. And what they did is they randomized kids to a high ad, which was 2.5 diopters an ad, a medium ad, which was 1.5 diopters, and then it's a single vision. And what they found was that the high ad reduced refractive error and axial length to a clinically meaningful level. However, there was not a significant reduction with the medium ad, which was the 1.5. Another study I always like to refer to is the MySight study, which had a +2 ad. And again, they had a significant reduction in refractive error. So when I talk to people about this in a lecture, I like to say you should pick an ad that's at least 2 or more because we know that the 1.5 didn't work in Blink. With that, there's a theory that the higher the ad, the better. But Amelia, you hit on the point that, high ads may make it hard to see. So typically in clinic, we stick around that +2.5. However, in this study, they had a progressive addition to sort of lens where they had a +3 ad in the periphery that went all the way up to 5.5. And interestingly, this study probably had less of a clinically meaningful effect than those other 2 studies that I just mentioned with the lower ads. So maybe that's another reason why we want to pick this, kind of middle of the road ad for these patients.
So, Andrew, another question kind of related to this study is the question of multifocal contact lenses, and we'll put MySight into that category because again, this multifocality is a really, really interesting area, and we certainly are learning more about it. But how does it compare in terms of its myopia slowing of progression compared to other treatments that we have? None that are FDA approved in the US as of yet, but all these other things that we're seeing coming out, and also things that we have access to, orthokeratology, compounded atropine.
So there's a lot of on and off label options, as you mentioned, and there's a lot of studies out there. And within each of those categories, there's a big variability in efficacy, but they all have a clinically meaningful level of reduction in general, depending upon what study you look at. So what I like to recommend to families is to pick the lens or really treatment option that works best for your lifestyle. So if you're a 5-year-old, 6-year-old kid, you're probably not going to pick contact lenses. That might be better for atropine. You can just put a drop in the morning. You don't have to fight kids at 7 in the morning to put a contact lens on, sort of thing. And then maybe a little bit older kids, they want to be free from glasses to play sports. That's the sort of thing that I was thinking about when I was in clinic, and I think that's what I would recommend to everyone going forward because there's really no clear winner in my mind. There's ones that work, and then really it comes down to what works best for you.
Yeah, I think the space is really interesting with the lenses that are approved in other places across the world, and in particular, too, companies that are looking at really harnessing the power of stable atropine and really having that as opposed to having the variability within the compounding pharmacies. I think in the next few years, in addition to the multifocal designs, we're just going to have a lot of other options. So it's a promising time to be communicating to parents and to kids about all of this. And we're just about out of time, but is there anything else you'd like to add? Any other thoughts on this topic or the paper that we talked about?
Well, I think this is a really interesting paper in general. I encourage you to read it. I think it helps us maybe better understand what ad power to pick, as we talked about. But with that, I think there really needs to be more research on this specific lens. We don't have it in the United States, but maybe it'll come here someday. So I think we really need to look at it, vet it well, and hopefully get some more data to say, hey, this is good, bad, or similar to what we got.
Dr. Andrew Pucker, it is always an absolute honor to connect with you. I've seen you come up through your career and just on a personal note, super proud of you. And thank you all for joining us on this episode of the American Academy of Optometry Foundation Clinical Podcast Series.
Thanks for having me. I'm here with a literal rock star, right?